comes with baclofen toxicity, correct? Baclofen toxicity is, there are various types of toxidromes you get. There are toxidromes, but we are not talking about toxidromes. We are talking about what happens and how do you try to remove these toxins from the body. So one of the main modalities that you think of is removal, toxin removal. One is you try to absorb the toxin from where it is. The other is toxin removal. So one of the physical ways of removing is you do a gastric lavage and you take off the toxin, but that works only if it's within 30 minutes to 1 hour, ideally 30 minutes. Okay, otherwise it doesn't work. The other one is you physically absorb the toxin by giving activated charcoal. So it is absorbed there. Third thing is you flush it down by giving whole bowel irrigation. So there are various techniques to remove the toxin physically. The other technique is to actually remove the toxin via extracorporeal therapies, of which one of the extracorporeal therapy you should understand is dialysis. Now, which toxins, like for example, this patient has come in with the baclofen toxicity. Now, baclofen is a drug that acts on the GABA-B receptors. When it works on GABA-B receptors, it actually acts on the brain and makes the person become relaxed, make the patient go down. But if you have a patient on CKD and you get baclofen, it can create toxicology even at the normal dose. You don't need to be toxic dose. Even if you are giving 10 milligram, 5 milligram also, you can actually cause toxicity. So you're not supposed to give baclofen to patients who are on ESRD, who are on CKD and things like that. So there are various reasons why this can occur. Okay, they sometimes give 2 milligrams, they sometimes 1 milligram. So 5 to 10 milligram can be a problem. So whenever you're dialyzing patients, okay, such patients, which are the best toxins to dialyze? Okay, that's the first question. So you must know which are the best toxins that you can dialyze, which are the medicines that you can dialyze. So what are the principles of using hemodialysis as a filter to remove toxins? That's the question. Okay. So the first thing is patient should have a very low volume of distribution. What is the meaning of volume of distribution?
Amount of time it takes for if you give a drug, how much of time it takes to get distributed?
No, it's not time at all. It is a volume.
Volume amount.
It is a volume.
Yeah.
So what does this mean? That if my volume of distribution is small, okay, it means it is going to be in the blood. If my volume of distribution is big, it means it's distributing into the tissues, it is distributing into the brain, it is distributing into the organs, it is going everywhere else. That is volume of distribution. So this VD, you should have an idea which are those drugs which have got volume of distribution that is high. Okay, so like for example, TK cycline has got a high volume of distribution, it will go into all the systems. Baclofen has got a low volume of distribution, so it will remain mostly in the blood. You getting the point? Low volume. So if you have a low volume, I think like this. If your volume of distribution is high, you cannot remove the toxin because it's not in the blood. You get the point? So if you have a patient on dialysis, if you want to do dialysis and remove, dialysis is working on what? On the blood. If the blood itself is not in the blood, then what are you trying to remove? You getting the point? So that's why you must know the volume of distribution. Clear on this? Clear on this first? If the volume of distribution is low, I can take off the drug from dialysis. Number one. Now, what is the second thing? The second thing is protein binding. Remember this, our dialysis membranes will not allow the protein to pass across. You're getting the point? That's why if you dialyze, albumin girta nahi hai patient. Albumin doesn't go down. Albumin is a large molecule. Anything, what is large? Definition of large is anything more than 500 kilodaltons. Anything more than 500 kilodaltons. Your BUN, your creatinine, your urea, all these very small molecules, in between 20s and 30s and 40s, that is the size. So those molecules are easily cleared out. Okay, cytokines come as middle molecules, somewhere between 500 to 1000. Okay, and anything more than that are large molecules. Anything more than 1000 is clear, large molecules. Now when you have large molecules now, those large molecules cannot be filtered. So albumin is a large molecule. So if you have a drug that binds to albumin, it cannot be dialyzed. It is poorly dialyzed. So how much percentage binding? We say more than 90 to 95% protein binding. So for example, warfarin. Now warfarin is a drug that once you give to the body, it immediately binds to the albumin. So 95% protein bound. When it is 95% protein bound, what is going to happen to warfarin? It cannot be taken out. So tomorrow if you have a warfarin toxicity and you say let's dialyze and take it out, it don't make sense at all. Okay. So the second thing is protein binding. Okay.
More than 90%.
Yeah. Polymer distribution. The other is molecular weight, size. So if the size of the molecule is big, you can't filter it out. You understand? If the size of the molecule is small, you can easily filter it out. Like this is a small molecule, so it can be easily filtered. You don't need to change the dialysis filter also. You understand? You don't need to change the dialysis because it's a usual molecule that can be filtered out otherwise. Clear on this? The fourth is lipophilicity. Now, what is lipophilicity? Lipophilicity means you have given the molecule and it has gone and got stuck into the brain. So lipophilic molecules will enter into the brain very quickly. So what happens to these molecules? They are maximally gone outside the system in the vascular compartment and gone outside. Since it's gone outside, it's very difficult to actually dialyze them because it's lipophilic, it's gone out. So this is how you can actually look at this. So there are two types. The thing is which membranes you use. There are two kinds of membranes: high flux and low flux. So these words are what is used: high flux and low flux. Okay, high flux means you are getting off more molecules. Low flux means you're getting off lower molecules. Bigger, higher pores, smaller pores. So when there are high flux and low flux dialysis. Now once you are 100, 1000 to 1000 to 1500 size, say 500 say 1500, 500 to 1500 if the size of a molecule is kilodaltons. If it is in this range, you cannot use a low flux dialysis. Pores are small, so that will not work in such molecules. So for such molecules you require high flux. So tomorrow if you want to remove cytokines from the body, you want to remove bigger molecules from the body, you need these kind of things. That is when the flux of the dialyzer changes. It's like a sieving, pore sieving versus fine sieving. So the principles of dialysis you must understand. Principles, that's very, very essential to understand. Like for example, lipophilic, midazolam, it gets into the brain, propofol gets into the brain. You can't dialyze this out. You can't dialyze this out. Protein binding, volume of distribution. Understood? On dialysis, how to use dialysis? Okay?